it's a little bit daunting for me to debate Dr. Arextabala from Chile, where gallbladder cancer is a very common disease. And we see it in New York, but certainly not to the extent that you do or you do in India. So, radical cholecystectomy for T1 gallbladder cancer. What does radical really mean? I think we should just, it's something that I've always wanted to talk a little bit about, because when we think of radical, the word radical in the English dictionary is not a very good connotation word. Most people view it to mean extreme or some departure from the norm or something crazy, radical politics and radical thinking. But when Halsted first coined the term radical mastectomy, he didn't mean it in that way. What he meant was pertaining to the root of origin or reaching to the center or the foundation. So in his view, a radical cholecystectomy was to remove the cancer and its roots. And so when we think about gallbladder cancer, T1b gallbladder cancer, here, this is what it looks like. This is the flower, the primary tumor, but there's also roots of cancer. And if we just do a cholecystectomy alone, we're like this little girl in the field picking the flowers. But in fact, in order to eradicate the cancer, you must get the roots completely. So what is the objective of surgery with gallbladder cancer? We could certainly spend all afternoon talking about what the appropriate operation is and how it should be done. But for patients with non-disseminated disease, the optimal operation is clearance of cancer from this area. Whether it is done with a limited resection or something more extensive, again, is not the objective of this debate. But we clear all the cancer from the gallbladder fossa, the adjacent liver, occasionally adjacent other organs, as well as portohepatis. So this operation removes both the flower and the roots. And I'm here to argue that T1b gallbladder cancer has roots, and picking the flower alone is not enough. So gallbladder cancer, when it presents, one of two ways: no prior cholecystectomy or prior cholecystectomy non-curative. And this is what we see most often in the U.S. and particularly in New York. This is an incidental finding after a cholecystectomy. And when we see this, the most important next step is to understand the depth of invasion of the cancer. And this is just a summary of the histologic appearance of the gallbladder wall. And T1a tumors are confined to the mucosal layer, very superficial malignant change. T1b tumors are invading into the muscularis layer. And even though that's fairly superficial in the wall of the gallbladder, that's enough to plant the seeds of cancer that need to be removed. And everyone knows that the T stage is the most important variable that the surgeon has available to him or her at the time of cholecystectomy or after cholecystectomy. It's well documented, as this data, which is now several years old for Memorial, T stage correlates with the likelihood of finding residual disease, the likelihood of finding nodal metastasis, and it therefore requires a critical reexamen by your pathologist to accurately document the level of invasion, because it's clear that certainly some T1 tumors don't require re-resection. This is data from our series, again, from Fong several years ago, early on, stratified by T stage and looking at long-term survival, T1, T2, T3. This is a bit deceiving because many of these, first of all, small numbers, and many of these were T1a tumors. Now, the proof that definitive resection for T2 and T3 tumors improves outcome, we've only arrived at by retrospective analysis of data, but the data is fairly compelling for this level of invasion. And here in this series, T2 tumors treated by definitive resection, 5-year survival 61% versus cholecystectomy alone, much lower, and similar, although lower, survival figures for T3 tumors. This is more recent data, a multi-center study from Europe, 429 patients, and again, showing that re-resection for T2 and T3 tumors is associated with a much better outcome. So in the absence of advanced disease, T2 and T3 tumors do benefit from reoperation. T4 tumors likely not even part of this discussion because they're much more advanced and they're usually not confused for or found incidentally. T1 tumors remain an area of some controversy. I think it's clear that T1a disease is cured by cholecystectomy alone. The data is fairly compelling for that. T1b tumors, I think in the past has been more controversial than it is now. There have been prior studies that have shown 10-year survival of about 90% with cholecystectomy alone in this setting. And Dr. Arax-Dabala will probably show some of those older studies. Other studies, on the other hand, have shown lymph node metastases up to 15% of cases. So there was some controversy about how the surgeon should proceed. I think that controversy has largely been dispelled. This is a study, a more recent study actually from Korea, that I think contributed somewhat to this controversy. 2009 paper, 33 patients with gallbladder cancer. Patients with T1 tumors did not undergo reoperation, had an excellent long-term survival, led the authors to suggest that these patients don't need reoperation. But if you look carefully at the data, there are only 12 patients. 2 of them had carcinoma in situ alone, and 6 of them were T1a. And of course, you're going to see a survival curve like that with that level of invasion. So patient selection based on T-stage. The recommendation for reoperation and definitive resection is based on the likelihood of finding residual disease. It's also based on the assumption that resection will improve the natural history, and that's still an assumption because it's never been proven in a prospective randomized study. So what is the risk of residual disease with T1b gallbladder cancer? I will show you data now that clearly demonstrates that it's much higher than previously thought. This is data from Memorial that's in press for publication, looking at residual disease by T-stage in patients with incidental gallbladder cancer. T1b patients, not a large percentage of the group, but not trivial. 5 out of 14, 36% of patients had residual disease on re-exploration. This is data published, a summary of the published data in a review study published a few years ago, once again showing patients with T1b tumors, 38 to 40% of patients with residual disease at re-exploration. That's at any site, local or distant. And what about survival? This is a study published recently from Los Angeles, Anton Bilchik, who looked at the NCI, National Cancer Institute of the United States, the SEER database. This is a large population-based collection of data in the U.S. of patients with all types of cancer. Over 1,000 patients with T1 tumors. You see here T1a patients numbered 300, T1b over 500. Another group of 280 or so patients where the T1 stage couldn't be determined. And then they analyzed the outcome based on type of resection. You can see here patients with T1a tumors did fine with cholecystectomy alone or cholecystectomy plus lymphadenectomy or radical cholecystectomy. No real difference among these groups. Not so for T1b tumors. T1b tumors, clear advantage for patients who had a radical cholecystectomy over cholecystectomy alone. And this is a German study published in 2008, a German registry study, 502 patients since 1997, 103 patients with T1 tumors stratified by depth of invasion and the treatment that was rendered, either re-resection or no re-resection or cholecystectomy alone. I'm sorry for the graph that didn't show through here, but it's clear. You can see the curve. T1b with reoperation, 42% 5-year survival versus, 79% compared to 42% for patients who just had cholecystectomy alone. So it seems fairly compelling that these patients require reoperation and definitive resection. So let me summarize by saying that T1b gallbladder carcinoma has roots. There's a high risk of residual disease, and therefore radical resection is required in all of these patients. This is associated with a lower recurrence and better survival, and cholecystectomy alone is just not an adequate therapy. Thank you very much for your attention.